So, Dr. Hall, welcome. Of course, we're here at ASCRS, San Diego, 2025. And my understanding is you've been a colorectal surgeon for years. You're the head of Tufts. You're chairman of surgery at Tufts University, Harvard trained. This is obviously your specialty. Where do you see the current position of colorectal surgery in the world, and what do you see as the greatest advances coming out in the last couple of years?
Yeah, I mean, first of all, it's really great to be here in San Diego with seeing and catching up with a lot of colleagues and old friends, and meeting the next generation of folks who are going to lead colorectal surgery. Is really an exciting time. Colorectal surgery has always been interesting to me because it's a combination of a lot of different things. You have to be good with people because you're talking about sensitive subjects and sensitive areas of the body. You are involved in some technology. We're undergoing a robotic revolution in colorectal surgery. A lot of our surgeons have transitioned from laparoscopic platforms to a more robotic approach to things. We do endoscopy, and so advanced endoscopic procedures and those kind of things are of interest. And then if you think about the management of some of the major diseases that we see a lot of, like diverticulitis or rectal cancer, really our care of those diseases has revolutionized over the last couple decades. And it's very different than even when I started. So that's why it's good to come to a meeting like this, because you get the latest results. Every year you get a little bit of update on this or that, the latest in management of common diseases that people, that we see every day in people.
In your practice, what do you think's been the biggest change in your algorithm, your treatment strategy with some of these new advancements? I mean, TAMIS has come out, robotics has come out. How do you see that as changing your practice?
Yeah, I mean, I would say you'll edit out all of medicine has transitioned to be less invasive and to minimize the impact of the treatment on patients. So we still are addressing the main medical issue, but we're trying to decrease the physiological response to that treatment. So for example, with the diverticulitis, we've had lots of debates about the most appropriate way to treat diverticulitis. It used to be if you came in with Hinchey 3 or Hinchey 4 diverticulitis, you would automatically get a stoma. And I would say these days that option is at least optional or questioned. With rectal cancer, we've really moved to a place where we are treating many patients with neoadjuvant chemoradiotherapy and seeing complete pathologic responses 18 to 30% of the time. And so that's sort of decreasing the number of people that may need to have a real aggressive surgical radical intervention. So I would say the general trend has been towards less surgical treatment, or at least less invasive surgical treatment, if I had to take a broad swath at it.
Can we dive deeper on the diverticulitis? Yeah. I think we have a lot of general surgeons, of course, in the community, and what is the current algorithm or modality, or how, because you're saying you might even operate on a 4.
Yeah.
What do you do? How do you handle that?
Yeah, well, back when, I presume you and I are about the same age, but back when we trained, it was easy, right? So if you had one attack, you were under 50, you got an operation, right? And that was for uncomplicated disease. Yeah. If you had 2 attacks any age, uncomplicated, you had an operation. I would say we've drifted away from that, mostly because we know that most cases of diverticulitis that don't perforate with real bad sepsis, acidosis, hypotension, that don't need an emergency operation in the middle of the night, most of those folks will do just fine on antibiotics. And then the question is, will they have smoldering symptoms over time, and will you need to do something to alleviate their symptoms with surgery? So to be clear, surgery still works great, but we've in many ways moved away from the strict algorithm of 1 or 2 attacks, then you automatically get surgery. What I would say is, like if we start with Hinchy 4, the most severe, and as a trauma surgeon, I presume that you're seeing a lot of that, which is folks who have some massive physiological response to the perforation. I think still appropriate to explore. You resect the section. In my mind, still very appropriate to do a Hartmann procedure and colostomy. But what if you're in the situation where you get in, you think it's Hinchy 4, and all you find is purulent peritonitis? The rectum seems pretty soft. The proximal colon seems pretty healthy and soft, and the only thing diseased is the area of the perforation. I think the evidence now would support the notion that you do not need to bring out a colostomy or divert that anastomosis necessarily if the two pieces of bowel are healthy and the patient is otherwise doing well from a physiologic perspective on the operating room table. Then you start backing down to the less severe presentations, so Hinchy 3. We've had lots of debates about laparoscopic lavage. We still continue to have a little bit of a debate about it. I think most people have moved away from it. But still, I think you could apply some of those same principles of either making an anastomosis in a diverting loop, or maybe just making an anastomosis and leaving it unprotected, depending on bowel quality. And then I think the more interesting presentations are, patients that present with an abscess. You drain it percutaneously, they do well. The drain comes out and they're back in your office asking, well, do I need an elective operation? And I think most of the data that we see now suggests that, yeah, those folks are at high risk for recurrence. 50 to 60, 75% of them will come back within a couple years with another presentation of diverticulitis, but seldom is it a massive perforation. And so we've got some time to talk about options. In my experience, I find that a lot of those folks come back with chronic symptoms. They never really quite get well, in which case we just end up doing an operation a few months down the line.
But even then, nowadays it's going to be robotic. So.
Yeah. Well, it's funny. I trained with Peter Marcello and the Leahy group, and I learned how to do hand assist laparoscopy. And now my practice has shifted completely to robotic surgery, with the exception of referrals for abdominal wall stuff or really sort of complex reoperative surgery. But most of my practice electively is shifted towards robotic surgery.
Yeah, I want to go back a second.
Yeah.
Under the Hinchy 3s, like there are some that you're not even doing a diverting loop. You're just if it's healthy enough and the tissue's soft and
the patient's doing well.
Okay, so
right.
If they're not unstable.
Right. Yeah, if they're not unstable and I have two healthy pieces of bowel and the operation has been otherwise simple, I will just put them together. And the last caveat, if the proximal colon isn't chock full of stool, right? Because if the proximal colon is full of stool, I make an anastomosis, they leak, that's going to be an issue. If I make an ileostomy and they have a colon chock full of stool and they leak, that's going to be an issue. So in a patient that is full of stool, I would probably just bring up the colostomy. That seems like the safest thing in the middle of the night.
No.
And even though Hartmann procedures they're on the more challenging side of procedures that we do, they're not that difficult. And so I think taking that risk at night may not be the wisest, if not all of the factors are there.
As a leader in the field, where do you see technology in terms of AI taking this field, or surgery in general? Where do you see it going?
I think there is gonna be. I'm not an AI expert, but from what I am seeing, there's going to be a number of ways that it's going to impact how we do our work. I think the first is very simple. We're now using ambient technology to help us scribe and take notes and take account of what we say to patients and really capture that visit and the essential elements of that visit, so we can really focus on using those intellectual skills to really diagnose and work with the patient and to spend a little bit more quality time with the patient and not typing. So that's like very basic.
Yeah.
But I think increasingly, I get approached by companies all the time who are using AI algorithms for not only anatomic identification using CT scans, but superimposition of imaging while you're operating. I think that will become probably come pretty soon in the next 3 to 5 years. I think that will be available. I do think the AI technology will help us better analyze data sets and understand relationships, cause and effect. So I think the sky's the limit in terms of what AI is going to accomplish and help with.
Have you been implementing any of this into your workflow?
For sure. We have implemented the scribe technology, sort of the ambient AI technology, so every surgeon in my department is eligible to use that. It's funny that not everybody has fallen in love with it. Like there's a few techie people like me that are interested in it and so have gotten involved with it, but the folks that have used it have really found it helpful. Some of the other stuff that's coming with AI, I think, is relatively on the early side. I think the other thing that's more ready for application right now is help with scheduling and case length analysis and those kind of things, analysis of big data sets around the OR. That's something that I'm very involved in, was optimizing the operating room flow. And there's a few companies that, well, more than a few, there's a bunch of companies that are in that space trying to help surgeons optimize. So those are the two things that I see that are closest. The image superimposition stuff, I don't want to name the companies, but there's a few of them that are ahead of the others.
Yeah.
So I think the ones that are closest will be in their next generation model.
And obviously you also train residents,
Yeah.
fellows in the upcoming generation.
Mm-hmm.
Are you seeing, where do you see their future problems are going to lie as all this technology comes in, or is there just advantages?
I think ironically, the biggest challenge for them is going to be their exposure to open surgery. So you and I started with a training algorithm that you always learned it open, and then you transition, other than laparoscopic cholecystectomy,
Yeah.
maybe, but almost everything else, you learned it open first, then you learned it laparoscopically or a minimally invasive way, and then as you became a fellow or an attending, you started to adopt robotic technology. What we're seeing now with some of the case numbers is there are very few open cases in some categories.
Well, I laugh because I had attending, even when I was in residency, I had attending say,
Right.
we're going to have to start sending you guys to maximally invasive fellowships
Right,
to really learn
right.
how to do this.
And so I think, one of my trainees approached me at M&M on last Thursday, and he said to me, well, Dr. Hall, what are we going to do? Like, we hardly ever do an open cholecystectomy. And I didn't really have a great answer for him. So it's something that it's a field that we need to really think about, because as you know, there are situations that you're only really going to be able to manage with fingers.
Yeah.
And having your first time be like when you're 3 years into practice is probably not ideal. So, thinking about mentorship programs, ways that we can, when I have something unique, I can invite my partners in to kind of, see what we're doing and kind of get a little bit of an understanding of, where, some options for dealing with it, I think are key. I think trauma and acute care surgery services are going to continue to be super key because they provide a lot of that open exposure to residents. So I'm really investing in those services and ensuring the residents have an appropriate amount of time to spend on those services and really learn.
Yeah.
Because on a lot of other services, it's like completely gone.
Yeah.
Right.
And I was asking somebody a couple months ago this question, but
Yeah.
now, before it was hard enough because you had laparoscopy and open, now you
Yeah.
have robotic laparoscopy and open.
Yeah.
where's laparoscopy's role in this? And because I mean, not every place has a robot, obviously. So
Yeah, and I think from what I've seen talking with my faculty, there's great enthusiasm for adopting robotic technology, and it's really in our institution just a question of access, right? Can I provide enough robots for all the people that want to do it?
yep.
So sometimes I will do stuff laparoscopically because like the robot's full, right? I wonder if that will plateau over time. I don't know where that's going to go, but I think the residents certainly are very enthusiastic about the robotic technology. They see value in it. They see that we haven't been able to prove this in big prospective trials, but from my point of view, the patients seem to recover more quickly, and even my ACS surgeons are really hot to trot to adopt the technology. So, like, we're doing, stuff at night on the robot now. So,
Yeah, I'm a huge fan of the robot. So
Yeah.
I'm 3,000 cases in, so I want to say
yeah, I mean,
it's
great.
amazing. And I always tell people you're not going to necessarily pick up some of the advantages in the data set because it's that mom that I didn't have to open up because I can now do this gallbladder that I wouldn't have had to do any other way. Or,
Yeah.
And I had a colorectal, a low anterior.
Yeah.
And third of the staple line didn't fire, and I'm down there just suturing it closed with the
Right.
robot, which I wouldn't have been able to do that laparoscopically. It was on the
Correct.
far side.
Right.
So it just opens up some opportunities that, once again, you're not going to necessarily show up in the data set, but you know that this scenario was different than anything you've seen.
No, I mean, some of the more advanced cases that you can do, and the patients go home the next day, assuming that you've done, the appropriate ERAS techniques, and they've been prepared in the office. We've really seen that we can send people home in 23 to 48 hours.
It's amazing. You're talking to Dr. Rashidi and Marina's earlier in their same day colorectal surgeries,
Yeah.
and I get the argument. I'm not here to poo-poo them at all. I think if you just told me that 5 years ago,
No.
I would have been no way.
Well, when I started residency, they all the colons would be admitted for 7 days, and they would have a nasogastric tube until they passed flatus. And then when they passed flatus, you could take and then start feeding, and that was day 4 or 5. They were there for a week. And this is really the idea when I come to talk to the residents at night, that the patient should walk, have clear liquids, eat breakfast in the morning. If they eat breakfast, the vitals are normal, labs are normal, then they go home that afternoon. It's really taken some work and some repetition. The idea that we got to call the patient to make sure they're okay at 36, 48 hours. So it's taken some reworking of the algorithms, but I think we've shown we've been able to do it safely.
So we're going to switch a little bit and focus
Yeah.
on ASCARs.
Yeah.
Obviously, 125th year here at ASCARs.
Yeah.
Where do you see the greatest value for this from the society?
Yeah, the way I've thought about ASCARs over the years, it is the single most organized entity that examines the field of colorectal surgery in a scientific way. And I think that's its real advantage, right? And so if you look at everything it does, from the symposia that they have here to the clinical practice guidelines that they put out on all of the major topics in colorectal surgery, from anal fissure to diverticulitis to Crohn's and ulcerative colitis to rectal cancer. I mean, even if they only did those 5, right, that's a giant help to the practicing surgeon, right? Because it's a systematic review, and it gives you some real clear recommendations for different options that you have for treating patients with common colorectal diseases. And they've even gone into, more esoteric stuff like deep vein thrombosis prophylaxis, those kind of things. So ASCAR provides that forum for real rigorous scientific thought about problems that we deal with every day as colorectal surgeons. It also provides a really close community, right? There are people here that I met on the interview trail in 2009, 5, right? And we've been friends for 20 years. And those are bonds that are really valuable just emotionally, but also professionally over time. So a lot of folks have gotten their leadership training here at ASCRS. The last thing I would say is it's a real organization that focuses on advocacy for patients with colorectal diseases, because when you have one of them, even if something as simple as an anal fissure, as you know, patients will come in and just say, like, has this ever happened to somebody else, right? So to have an organization that can really advocate for the care of patients with stomas or Crohn's and colitis or those kind of things is really, really powerful.
Speaking of general population of patients,
Yeah.
if you were going to talk to a patient today and say, this is the greatest advancement in colorectal in the last 20 years, and if you're going to deal with somebody or go to a colorectal surgeon or a general surgeon,
Yeah.
you need to make sure that they're doing whatever this is, what would it be?
Let me make sure I understand your question. So you're asking, where have we made the most advances in colorectal
Yeah,
surgery?
it's something that you can, but speaking to a patient, like
Yeah.
not to another surgeon, what would you tell them?
Yeah, I would say that I think it's hard to underestimate the impact of minimally invasive surgery, right? Even if you just took the difference that laparoscopy made in comparison to open surgery, and a lot of the thinking about combining minimally invasive surgery with enhanced recovery techniques, that's had a huge impact on the way patients are cared for, the amount of time they spend in the hospital, the length of stay, and I believe in postoperative complications and morbidity. I would say the other major thing that's changed is that people are living longer with cancer, right? So when we do, we've understood the importance of early colorectal cancer screening. But when we do make a diagnosis of colon or rectal cancer, oftentimes it's curable. And even when it presents with advanced disease, patients are living on the order of years now, which was very different than when I started. So there's lots of different treatment options. And patients have a lot of clinical trials that are available for them to benefit from. So those would be the things that I would think have made the biggest impact.
I have to tell you, it was the most eye-opening thing I've heard since I've been here is TAMIS. Like I'd been hearing about it for the last couple of years, and then to hear the data on it, like that's a game changer from a.
Yeah, well, not only TAMIS, but if you take like ESD, like endoscopic submucosal resection, and EMR, and you take all of those three together in terms of our ability to deal with advanced polyps or malignant polyps, they're real game changers, and it's actually changed our recommendations on some of those things, right?
Yeah. So I always like to end with, in all of your years, I always say there's knowledge and wisdom. Knowledge is stuff you get out of the books, wisdom is stuff you have to experience. Be it clinical, patient care, leadership, what is one thing that you would say is a pearl of wisdom that you've learned all of these years that you want to spread or share to other surgeons?
I think it's still all about the basics, right? So Charlie McCabe, who was my third year clerkship director, always told us, if you take care of the patients will take care of you, right? And so the one thing that you'll see about ASCRS and all of the colorectal surgeons, almost all of them, they'll be leaders in their hospital. And because there's that real ethos of commitment to patient care and being there for the patient first. And all of my mentors here in the society, Dave Sheds, Pat Roberts, Tom Reed, Jim Fleshman, people of that level, they all had that same commitment to patient care. And it's very hard to get away from that once you've been trained in that way. And the patients really do appreciate it. They come to see you as their primary care surgeon, right? Because you're taking care of their issues. So.
See, I always thought that you guys did that because you weren't on call all the time and you didn't have to, so you had more energy than we did. That's not it?
Well, I mean, I think it kind of depends on the setup, right? you know, some places the colorectal surgeons take primary emergency call for those kind of issues. I think that's becoming less and less as, you know, trauma and acute care surgery has developed as a field.
Yeah.
But really, these tend to be like a complex set of issues, and you know, even with somebody with a stoma that has no complications, just sitting there and holding their hand and telling them it's going to be okay and we're going to get this thing back together in 6 months is really, really comforting, right? Because sometimes they've never heard that.
Yeah, no, I think you're right. I think we forget sometimes the psychological effect of what we do to the patients and the effect it's having on them, especially stuff like, I mean, what you're dealing with here.
Yeah.
Like having months of, you know, just poop coming out of your belly.
Yeah.
It's somebody used the term PTSD for the first time, and I never thought it was probably true.
Yeah, it's a game changer for many patients, and if you can be there for them, they really, really, really appreciate it.
Well, I have to thank you so much for your time, Dr. Hall. It's been amazing to get a chance to meet you.
It was really nice to meet you.
Appreciate
I enjoy
you.
what you're doing.
Well, thank you so much.
Yeah.
Enjoy the rest of your conference in San Diego.
Thank you.